structure and some endogenous antigen. Now, body mistakenly attacks the self-specific antigen, thinking it to be foreign body, and then causes that damage, tissue damage at that particular site. It's a time clock. It's the phases, the four phases of contagion process, starting with the susceptibility. It starts much before the clinical manifestation of the disease. So what happens in susceptibility is there is the tolerance, the central tolerance, induction of central tolerance, which happens in thymus, doesn't happen, or there is some problem, defect. Then there could be also peripheral induction problem in the during the process of apoptosis. Also, there would be altered production of T regulatory cells. All these status and there is something called clinical manifestation of SLE. We have already seen it since many years, and it shows how the systemic lupus erythematosus affects almost all the organs of the body. And so there are some criteria for diagnosis of SLE. The recent one is of 2019 by the American College of Rheumatology, and so they have what they have said now that a titer of 1 is to 80, more than titer of 1 is to 80 is the entry point of the definition. So if your AMA titer is less than 1 is to 80, you don't follow up with all this schooling. So your entry criteria is more than 1 is to 80. So apart from that, you have to have a total score of 10 or more. So there are domains, there are 4 domains, like there are certain clinical features, constitutional, hematological, neuropsychiatric, mucocutaneous, and likewise it has been there in the scoring system, and points are given. Immunological domain is there, complement proteins and specific antibodies. So you have to take the history, give the scoring, and if you add up, if it comes more than 10, then you can define it as a SLE or collagen vascular disease. This is the characteristic butterfly rash in the face seen in SLE and the rashes in the other parts of the body. Also, lower towards lower right towards me, you can see this is the immunofluorescence picture. It's the head to substrate, and it's a green color. You can see these are the green color nucleus. This is the homogeneous positive pattern seen in SLE. So green color, something green in immunofluorescence is considered positive. Okay. Beside that, you can see the urinary sediments, which commonly seen in lupus nephritis when the kidney is affected. So these are the investigations. So routine lab investigations should be done, including CBC, ASR, uric acid, total protein, serum albumin, urine microalbuminuria, along with ANE. ANE is very important. It is anti-nuclear antibody. You may say that ANE is the CBC of autoimmune disease. If some patient has fever, the clinician says run a CBC. If you see high WBC count, then you decide further that okay, it could be bacterial and viral. Likewise, you decide the further test. Similarly, in ANA, it is the starting point in autoimmune disease. So, looking at the title of the ANA, you later then decide about what reflex test you need to do. So, if your ANA is positive, what will you do? You will do a dsDNA. If ANA and dsDNA both are positive, SNA. Also, you can do ANA and reflex extractable nuclear antigen. Extractable nuclear antigen is the second step after ANA is positive, and here you find out the second subtype of antibodies present. And likewise, you can further classify, like if it is SSA, SSB, you are dealing with Sjogren, or it is topoisomerase 70, you are dealing with diffuse systemic sclerosis. Likewise. So, after, if all these things are negative, you will also see the rheumatic factors, anti-CCP. And if those are positive, you will think of rheumatoid arthritis. Then you can go for ANCA. ANCA is a diagnostic for your inflammatory bowel vasculitis. and HLA-B27 for ankylosing spondylitis. So this is the way you will decide the investigation. So something about the ANA profile. ANA is very sensitive to rule out SLE. It has a very strong negative predictive value for SLEs. And a positive test does not confirm a disease because low titers are also seen in normal patients. Little bit about the history. Cell was introduced in 1948. Cell was the telltale sign of immunological disease. Here you see the Cell is something called neutrophil or macrophages, which phagocytose the nuclear debris of damaged cells. Then in 51, the gamma globulin fraction was, any factor was located in the gamma globulin fraction. In 1955, we developed the Hep2 cell line, which is still followed right now. Hep2 is the substrate on which the ANA testing is done. In 1957, the pattern of reporting was established. Previous to that, intensity was used for reporting. Then in 58, N1 titer was introduced. This is very important. And in 1994 and 95, Hep2 cell line along with human 60 kDa protein was introduced. And right now, biochip titer brain technology is used and it's coming up in SRL also in 1 to 2 months. So it's a newer substrate which gives quicker results, more accurate and precise reports. So as I was saying, 1 to 5% of healthy people have ANA positivity. And also in elderly patients who have non-rheumatological illness also have low titer, that is 1 is to 40, 1 is to 160 titers. But also you can see that as the titer increases, it is more towards an autoimmune disease. Like a titer of more than 1 is to 320 is very rare in a healthy individual. Okay. There are two methods, IFA, which is the gold standard, another is the ELISA. These are the substrates used. Rodent tissue nowadays it is not used. Hep2 cell line is used as a substrate. It gives a very large nucleus to study, and then mitotic cells are present, so it is very helpful to report on Hep2 cell line. Biochip titrating is a step further and it combines two substrates, F2010 in primate liver, and it gives a better, you can see in the diagram, the cover slip has some biochips, so it reduces the need of an nidification chamber and it gives brighter immunity, brighter, what do you say, fluorescence, and it is very easy in reporting. Some ANA positive cases are starting from SLE, mixed connective tissue disease, RA, juvenile chronic polyarthritis, Joplin syndrome, polymyositis, and vasculitis. Some infections and neoplastic disease and certain hepatitis, thyroiditis also gives positive ANA titers. If the ANA is negative, it excludes a SLE. And what next you have to do? You have to see the possibilities of anti-juvenile polymyositis and other cytoplasmic positive uh, immune disorders. If you see the percentage of positive test results with ANA, the highest is the SLE and the rheumatoid hepatitis, where more than 95% cases will have ANA positive. Now, and scleroderma, Sjogren's disease, polyarthritis will have a descending means chronologically descending positivity percentage. So, if you summarize in a flow chart, a proper history and physical examination, and if there is organism suspected, you do a ANA screening. If it is positive, you do a reflex, adaptable nuclear antigen test, and then the further subtyping can be done. And if it is negative, you have to reassess your clinical findings. Very important thing is if ANA is negative, but there is a very strong suspicion, clinical suspicion, then you need to repeat it after 3 to 4 weeks. What happens sometimes the patients are on steroids and that can affect the ANA titer. So you have to speak with your clinician. If there is a very strong suspicion, you have to repeat it after 3 to 4 weeks. And if the patient is taking steroids, you have to stop the treatment, and after adequate time interval, you have to repeat it. So this is the traditional testing pattern. You have to screen with immunofluorescence or ELISA. In reporting, you have to, every lab has to report the pattern by IFA. M titer is must, and then they have to do the dsDNA, and if the ANA is positive, you have to do the ENA screening. This is the fluorescent picture of the patterns which I have been seeing. If you, I don't know, I don't have a pointer, but see, the third column from my side, top one, you see very small green positivity, not covering the whole of the nucleus. That is called the centromere pattern. Below that, there is the nuclear pattern where 2 to 7 bigger dots in the centromere are present in the nucleus. So that is the nuclear pattern. And below that, there is a speckled pattern where the whole of the nucleus is covered with smaller dots, and it could be coarse type or fine type. And extreme light, you can see it under the homogeneous. You can see the entire nucleus is uniformly positive for green color. So that is the homogeneous. So what are the possibilities after a positive ANA and the pattern? See, if homogeneous pattern can be seen in so many types, SLE, RA, drug-induced SLE. So further, if you do the extractable nuclear antigen, you can come forward with these things. Like if it's SSA, job and SSB, this job and RMP can be seen in mixed connective tissue, SLE. Topoisomerase topoisomerase 70 is very classic for diffuse type of scleroderma. Likewise, in nuclear pattern, you can see in Raynaud's scleroderma, polymyositis. Centromere pattern, you can see in CREST, Raynaud's and mixed connective tissue disorder. Cytoplasmic pattern is seen in non-collateral vascular diseases. It is usually seen in myositis or in mitochondrial means AMA, anti-mitochondrial antibodies seen in practically cholangitis. So, as I said in the history also, that previously intensity was used. But see, intensity has a problem. See, my 3 plus reporting means reporting is done by 1 plus 2 plus 3 plus 4 plus positivity. So, my 3 plus can be somebody else 2 plus. So that's why intensity is not being used for reporting and titer is used. So does has intensity has any role? Yes, it has a role where, see for example, your first titer 1 is to 40 is positive and intensity is 3 plus. So you will not invest your resources and do 1 is to 80 or 1 is to 60. You will directly jump to 1 is to 320. So you can save your resources, and likewise, and then till the last titer, till there is no positivity, that will be the last titer. Again, in the second scenario, if it is 1 is to 40, but your intensity is 1 plus, then you have to 1 is to 80, 1 is to 60, 1 is to 320, likewise. So as I said, ANA predictive value is, positive predictive value is very less. So it's 1 is to 40 is seen in only 0.9% of SLE, means the positive predictive value. And at a titer of 1 is to 320 or higher, a positive ANA test in isolation has a positive predictive value of only 2.45%. So positive predictive value is very low. However, the negative predictive value is very strong. Like, see, if absence of ANA at a titer of 1 is to 320 or higher has a negative predictive value of 99% in an unselected population. So to maximize the negative predictive value, you should, means I will say that you should do ANA profiling in negative cases also, because it will strengthen your negative predictive value. Something about the dsDNA. dsDNA is the double stranded DNA antibodies against dsDNA. The substrate is different. I was talking about HEP2, now it is Cystridia lucidi. It's a flagellate, a protozoan flagellate, in which the test is done, and this dsDNA is found in 40. So this is how it looks under the fluorescence microscope. It looks under the fluorescence microscope. There is a big kinetoblast positivity which can be seen, and it is reported positive. 1:10 is the cutoff titer. So extractable nuclear antigen, which are the same. This is extractable because the nuclear proteins can be extracted out of the nucleus by saline method. Two methods. If it is a low titer, then you see the clinical suspicion. If there is a strong clinical suspicion, you can still go for ENA, and if the patient has those markers, it will be considered positive. So these are the panels which are present in SRL. We have customized panels also. So ANA IF1 F2, then there is ANA IF reflex to ENA profiling, and then there is some comprehensive ENA profiling, and the sample is serum, specimen is 3 ml volume, 2 to 8 degree temperature, and it's a same-day reporting. There is also a combination of ANA and dsDNA with titer. Sample is serum, method is immunofluorescence, specimen volume is 3 ml, and a same-day reporting. This is a dummy report. So, as I was saying, in the cytoplasmic staining, it rules out SN. So, most common disorder for cytoplasmic positivity is autoimmune hepatitis. So, you have to, and there are other cases also. So, coming to the autoimmune hepatitis, it's the inflammation of the liver, and there is elevation of liver transaminases, autoantibodies, gamma globulin levels are raised, and there is an enteric hepatitis under the histopathology. So, the autoantibodies which are related to hepatitis are anti-nuclear antibody, anti-smooth muscle antibody, LKM, that is liver kidney microsomal antibody type 1, liver cytosol antibody, and there is a soluble liver antigen and liver pancreatic antigen. So what happens if your ANA and smooth muscle is positive, you are probably dealing with AIH type 1. If the LKM is positive, you are dealing with AIH type 2. And if your mitochondria is positive, your antigen, if that is positive, it is the type 3 one. So in some diagnostic difficult cases, in 10 to 20% of patients, the smooth muscle antigen antibody against the smooth muscle is negative. So in those cases, you can do a PMA, and if it is positive, it hints towards the autoimmune disorder. Also, chronic hepatitis C virus, they have an overlap. So in those confusing cases, also the PMA positivity helps in the diagnosis. This is a picture. Also here the substrate is not here. Here the substrate is not Cystridia. Here the substrate is called MSK. MSK is the mouse stomach kidney. The upper part is the stomach, lower part is the kidney. So you see the middle part is the muscle. So muscles there is highlighted by green color. So as I said, green color is positive, muscle is positive, diagnosis is asthma, it is AIH. This is the mitochondrial pattern. Here you can see the SMA muscle is negative. Upper part, parietal cells of the stomach is positive. Lower down, renal tubules are positive. So the inside nucleus is negative. Outside cytoplasm is positive. MSK substrate is used for other antibody detection also. Antiparietal, antiribosomal, brush-coated antibody, and reticulin antibody. So these are the panels available. In the panel 1, in SRL, we have the ANA, SMA, AMA, and LKM. These are different combinations we have. The methods are either immunofluorescence or ELISA, serum sample, 3 ml volume is required, 2 to 8 degree or frozen, and the reporting is same day. Few words on the ANCA. ANCA is the diagnostic marker for autoimmune vasculitis. So what is the full form? Is the antibody against the uh, cytoplasm of the neutrophil, cytoplasmic protein of the neutrophil. So what happens is they attack the antibodies attack the neutrophil cytoplasmic proteins, and by alternate complement pathways, they attack it acts as a chemoattractant, causing all the inflammatory cells to gather around that tissue and leads to tissue destruction. This is the picture of the ANCA. See, the substrate is the neutrophil. The lens has a neutrophil. Patient serum is poured in, intubated. If you have ANCA, if the patient has ANCA, then it gets absorbed, and with the excitation of certain frequency, you see it under the fluorescent microscope. See, in the C ANCA, you can see the cell border of the cell. Cell border is there. Inside nucleus is negative. Cytoplasm is positive. It is the cytoplasm panel. In P ANCA, if you carefully see, the cell border is not highlighted. It is the perinucleus. The nucleus around the nucleus, the positivity is there. So this is the P ANCA positivity. So if you have a ANCA positivity with either P ANCA or C although there are other diseases also. Okay? This is the dummy report, and the cutoff pattern is N type. Some, as the name suggests, it is the inflammation of the muscles. It's a progressive disorder. IIM, then is the intrusion body myositis, dermatomyositis, and there is a polymyositis. There is something called overlap myositis also. There are other autoimmune diseases who coexist with myositis. So lower down you can see a host of secondary antibodies which are detected by ENE, and it helps in further classification. So see, if you remember in my when I was talking about the mechanism of autoimmunity, the clinical phenotype depends upon the specific target antigen. Then antibody against those target antigen helps in the diagnosis. So you can see that these are tissue-specific antigens, like for example SRP. So if we are detecting SRP, and you can see the clinical phenotype is severe myopathy, dysphagia. So likewise these are related, and you can see the mechanics and Raynaud's phenomena, arthritis. These are related. This clinical phenotype is seen in anti-synthetase syndrome, and these antibodies are against the amino galaxy RNA synthetase. So these autoantibodies, myositis autoantibodies have an increased utility in both diagnostic and as prognostic biomarkers, and it helps in the classification. So infection or any trigger they cause an inflammation, and the inflammation response goes haywire. Then the body is the target rather than the extraneous antigen, and particularly bleeding, typical papules, periorbital edema, and Shaw's sign seen in myositis. So myositis is a very rare disorder. So exclusion is important in the diagnosis. Physical examination, muscle biopsy, EMG, electromyography, MRI, nerve conduction study, blood test for CPK, LDH should be done, ANA should be done, followed by myositis or to give a proper diagnosis. These are the panels which are available. It's two panels, 16 antigen and 11 antigen panels, and 11 antigen in the report. This is the dummy as you know, and the autoantibodies related to it are factor and anti-CCP. You can see there is a swollen synovial tissue, there is a erosion of the bones, which are characteristic finding the rheumatoid disease, and also there is a deformity. So the classification, the recent classification by the American College of Rheumatology 2000 the scoring should be more than 6. So there is categories like number of joints involved starting from 1 to 10, and likewise points are given. Serology consists of RA factor and anti-CCP, And the points are given. Acute phase reactants consisting of CRP and ESR points are given, and duration of symptoms more than 6 weeks and less than 6. So if we study this flow chart, for example, I will just integrate one of them, extreme left. See, I don't know how much it is visible. It's not visible to you all. So it's written that if more than 10 joints are involved, and your answer is yes, then you do the serology. Serology, if RA and anti-CCP are positive, you are taking with RA, rheumatoid arthritis. If the serology is negative, you ask the question whether it is the duration is more than 6 weeks or not. If it is yes, you are taking with RA, probably taking with RA. If the duration is less than 6 weeks, then you will ask for the acute phase reaction. If it is problematic, you are probably taking with it. So, for a diagnosis, the imaging like X-ray, MRI, DEXA scan, ESG, along with laboratory parameters like the autoantibodies, CIP, ENA is essential. Rheumatoid factor is the antibody against an antibody. Here the IgM antibody is against the Fc component of the IgG, and is seen in 70 to 90% of RA, and also seen in a healthy individual in 5 to 10% cases. Anti-CCP is more specific than RA factor because, as you will remember, I said that early part of the disease anti-CCP there appears in the blood. So early diagnosis and timely treatment is very important in the case of the rheumatoid arthritis. So anti-CCP is the preferred marker. And in studies it has been shown that um, uh, 50 to 60% of people with early RA they develop anti-CCP as early as 3 to 6 months. Okay, ESR and CRP, they are active phase reactions. CRP is more definitive and more sensitive marker of inflammatory markers. Now coming to the differential diagnosis, you should always do a ANA test to rule out other collagen diseases because it's self-explanatory. Like if your ENA extractable nuclear antigen shows all these antibodies, then you are probably dealing with some other autoimmune disorders. This is the test panel available. The sample is serum, 5 ml specimen is required, and it's a same-day reporting. Now, HLA-B27, it's a protein on all the surface of the body. It's related to the chromosome 6. Most common association is ankylosing spondylitis. You can see in the picture, spine is affected, vertebra is affected, destroyed, collagen is replaced. There is an autoimmune response against this collagen tissue. So, 80 to 90% of patients with ankylosing spondylitis, they have an HLA-B27 positivity. So, when do you get tested for HLA-B27? As I said, all those features, joint pain, stiffness, inflammation, and even if in the eyes you have uveitis, you should do an HLA-B27 test. So it can be done either by flow cytometry or PCR. PCR is the diagnostic method, and whole blood sample in EDTA bile is taken. Specimen volume is 3 ml, ambient temperature, and same day report. So this is the report of the HLA-B27, and see, it doesn't mean that it's a it gives a clue to the clinician that you are probably dealing with ankylosing spondylitis. So, so we all have other organ-specific autoimmune panel also, which I am not taking up in this CME. And so we have seen that there are so much of overlapping signs and symptoms that laboratory investigations are very much important and play a very valuable role in the diagnosis of autoimmune disease. So with this, I conclude my talk. Any questions?
Thank you, madam, for your wonderful presentation. And now I request the audience if you have any worries and queries, Madam is there to address. And as far as I am concerned, I have cleared some of the doubts, and I hope others will also. Because this is very important, it can involve any department from medicine, surgery, gynae, ENT, I think none of it. This, yeah, it involves all the system, therefore it is very important.
Thank you so much.
Yeah, on. Sorry, I reflected lately, and I have no worry, but I have a few queries. My first query is that since as Dr. Kundu has said, the process is a policy, I agree. But after we take of course, again we have to do a series of identification tests to conclude to finish the diagnosis. Now my query is it right to just directly go to the DNA profile instead of going through all series of tests to save the time and money and energy. It's right to test supposing a clinician or physicians they have strongly clinically diagnosed the person is suffering from. It's right to go directly to the DNA profile so that we can identify according to that protein identify the disease and go direct to the treatment.
I think the answer lies in your question only. You're saying the clinician has a strong suspicion, right? You can cut off all the other tests and you can directly jump to it. You see, it is the tests are done for the benefit of the clinician. It's the call of the clinician. If they want from the scratch, they want to rule out all the other things, they are not sure, then they have to do other things also. Like, they have to do the protein part, serum protein, you have to do the, yes, like that way. And also you have to remember that it's important in the prognosis also. You have to see, since it's especially important in systemic vascular diseases, where you have to beforehand, you have to know that which organs might get affected in the later course of the time. If the patient is not given timely, treatment. So for monitoring purpose also, you have to see other collateral markers of the lab. But for initial diagnosis, if you are 100% sure you are dealing with ANA, you directly start with ANA with reflex ANA. It's a customized thing. It's as per the clinician.
I'm asking about the profile.
Mhm.
In a profile where you see the series of it is a positive, you see the series of protein and asking
So you're asking about that immunoglobulin.
profile.
Yeah, ANA profile, yes. See, it's a immunoglobulin, the scripts are available. Okay, so strips have all those antigens. Usually they cannot say that only one antigen I will be testing. It's a strip. It's a strip with coded antibodies. So at a go, you will get it's very economical also. At a go, you will know all the subtypes if they are present. It's a see the basic
Then I going from that protein profile, you can see which the person is